Hi, everybody. Welcome to our Leukemia and Lymphoma Society's Living Well with Blood Cancer virtual conference. We will get started in just about a minute. So we are at 3 o'clock, and I think we will get started. If you could just advance to the first slide, please. So welcome to the Leukemia and Lymphoma Society's Living Well with a Blood Cancer virtual conference. Unexpectedly, pausing some of your life goals as you confront a blood cancer diagnosis may cause you a great deal of worry. When you're in or out of treatment or navigating a chronic blood cancer, taking care of your health and well-being are especially important. The week-long conference will offer you an interactive presentation and expert-approved tools, tips, and recommendations to improve your quality of life so that you can live well with or after a blood cancer. Let me introduce myself. My name is Leslie Ann Guiney, and I am the Community Services Manager for Eastern Ontario at the LLSC, and I'll be your host for this online event. This presentation will be approximately 60 minutes and will include a question and answer period at the end. Since there are many of you, we invited you to type your questions into the question box of your Zoom webinar panel throughout the presentation. An LLSC staff member will monitor the questions, and I will read some of your questions aloud at the end of the presentation during the question and answer period. The conference will also be recorded, therefore you can listen to this again on the website. Before we begin our main presentation, I would like to share with you our mission and highlight some of our resources that might be helpful for you or someone you know. At the LLSC, our mission is to cure blood cancers and improve the quality of life of those touched by a blood cancer and their families. We offer guidance and support every step of the way. The community services managers across Canada can help. They are compassionate connectors that can help you cope with your blood cancer experience. Please do not hesitate to contact the community services manager in your area. They can be reached by emailing info@bloodcancers.ca or by calling toll-free at 1-833-222-4884. Next slide, please. The LLSC has many free services to help you through, I'm having trouble here. The LLSC has many free services to help you through the blood cancer experience. One such service is our peer support program. It is a support service that matches people affected by blood cancer, caregivers, and their family with trained volunteers who have been touched firsthand by a blood cancer and shared similar experiences. Whenever possible, the participants and volunteers are matched based on their age, gender, diagnosis, or the issue that is most concerning to you. Next slide, please. On the new website, bloodcancers.ca, you will find a variety of educational resources and support services. For example, there you can access free booklets and fact sheets containing information about specific blood cancers, treatments, and practical information. You can also find short animated educational videos, past webcast recordings, as well access our many podcasts. Next slide, please. It is now my pleasure to introduce you to our conference and speaker for today. When cancer takes an emotional toll on you, a blood cancer diagnosis may unexpectedly pause some of your life goals and cause you a great deal of worry. As you navigate cancer treatment, it's important to look after your mental health. Treatment for depression, anxiety, and post-traumatic stress disorder, or PTSD, has important benefits for people living with cancer. Dr. Christian Schulz-Quach is an assistant professor and clinical educator in the Department of Psychiatry at the University of Toronto and a staff psychiatrist at the Princess Margaret Cancer Centre, Department of Supportive Care since November 2019. Over to you, Dr. Schulz-Quach.
Well, Leslie Ann, thank you so much for your introduction. Thank you for having me this afternoon. And I want to welcome everyone at the screen, wherever you are. I hear we're over 200 people. It is a shame that I cannot see you, but as I look at you, I welcome you this afternoon. I am aware that this is going to be a talk that for some of us is going to be very personal and very intimate. For others, it's maybe because you are the partner, the caregiver, or the significant other of someone who is struggling at the moment. I will, in my talk, try to reach out as much as I can. I will provide you with as much hands-on pragmatic support as I can. And I also want to encourage you to ask your questions, to bring those questions up, whether they will be discussed in the Q&A, and at the end we have 15 to 20 minutes for this, or whether the question will later on be discussed via email, via the LLSC Leukemia Lymphoma Society of Canada, who will be in touch with me afterwards to answer any outstanding questions. So I want to quickly go through what we will be discussing over the next 45 minutes. And I just want to quickly say I will be also willing to interrupt my talk at any moment in time if Leslie Ann signals that there are significant questions coming up. We will talk about distress as a sixth vital sign that we all should be very aware of when we talk about treating cancer, diagnosing, treating cancer, and living with cancer. I will talk about specific anxieties related to cancer-related anxiety, depression in cancer care, post-traumatic stress in particular as different from post-traumatic stress disorder, and then a very important construct in any form of traumatic consideration, post-traumatic growth. Now, as I advance to my next slide, I want to let you know that maybe I'll go to this slide, that in the upper right corner of most of my slides, you will find a fancy QR code. Most of you who are vaccinated will know that those QR codes from going to a restaurant, to a museum. And these QR codes here function as a reference for further reading if you are interested in a topic that's relevant for any of the given slides I'm going to show today. So if you would like to read up on systematic reviews or on background information on websites and on very hands-on resources available in your area, for each slide, I have put up a QR code which leads you to those information. If you haven't used QR codes before, all you do is you take your phone, you go on your phone as if you want to take a photo, then you hold the phone towards the QR code, and then automatically your phone will pick up the QR code and guide you to the website or link that is encoded in the QR code. So now going back to the sixth vital sign of distress, the reason I'm bringing this up is that the majority of patients who are diagnosed with cancer are patients who have no prior mental health history and are people like you and I who have, before their cancer diagnosis, often not struggled with any form of mental health disorder. This is very important to mention because what we typically in cancer psychiatry or psychosocial oncology consider is the level of distress any person goes through, normative distress, normative reactions to distressing life events, including sadness, anger, anxiety, or shame. And so that's why in any cancer center like Princess Margaret here in Toronto, we would be screening all of our patients for their level of distress, but not every patient actually needs specialist psychiatric or psychotherapeutic service. As a matter of fact, the most severely distressed 10 to 15% are the patients we often see in specialized services. and then a larger amount of 35 to 70% of patients can actually receive help through psychoeducation, self-help, peer supports, or lower tier support mechanisms. I do want to mention and emphasize that distress per se, so without even being at the level of mental health disorder as we would diagnose it in psychiatry, is often underdiagnosed and underdetected. It's often ignored, and that's why we try to emphasize that it is basically a sixth vital sign, just as taking the blood pressure or counting how fast your pulse is. Distress does respond to treatment, so even though we might not need to diagnose anything in particular, distress can easily be contained if we become aware of it early enough. Unfortunately, however, it's also true that if we disregard distress, the distress in a patient, the distress in a caregiver, or in a family system or a unit of care, it does actually link to poorer outcomes. And so there is an absolute incentive for anyone working in healthcare to watch out and look for signs of distress in patients. Now, as I'm talking here as a psychiatrist and psychotherapist, I want to focus on two particular network systems that play a significant role in what we would call the common pathway theory. The common pathway theory basically tries to explain how two neuronal networks in our brain are relevant to explain how distress turns into significant anxiety or potentially significant depression. On the one hand, it's the stress response network that will be activated through a significant and severe life event in any given situation. It is a question of the intensity of activation and also the time to compensate for this stress momentum that will lead to a normative stress response or to a stress response where the baseline all of a sudden jumps higher and you will always be at a higher stress level coming from a particular significant, potentially traumatic life event. At the same time, positive motivational networks in the brain get downregulated. And if they get downregulated at the same time that the stress response goes up, we're finding ourselves in the situation of allostatic overload, which I will talk to more later on. And we will find ourselves in a situation of anxiety and depression. What forms of anxiety are particularly relevant in cancer? When I see patients in my practice, in outpatient practice, or on the inpatient wards here at Princess Margaret, I'm one of the co-leads for the inpatient services, then I do not necessarily immediately jump to trying to find a diagnosis as a psychiatrist. The first thing I would ask myself is, this person in distress, this upset person in front of me, do I have any form of understanding why this person is distressed? Stiefel is a psychiatrist from Switzerland who very early started thinking about these matters in non-pathologizing terms, and he came up with a system that's actually quite helpful. He describes situational anxiety as being any anxiety that we would all normatively experience if we are in a stressful life event, including, for example, being confronted with a new diagnosis, a cancer diagnosis, or being confronted with the information of a recurrent or relapsed disease. Psychiatric anxiety would then speak to what we would commonly consider a psychiatrist being necessary for when we talk about specific phobias, when we speak about generalized anxiety disorder, GAD, or panic attacks, where I have significant physical symptoms that make me feel as if a tsunami is washing over me, or as if a train is running through the room and I literally am feeling in a freeze state and can't do anything. OCD, obsessive compulsive disorder, would be another form of anxiety disorder, or PTSD, post-traumatic stress disorder, which we will discuss later. Very often, however, in cancer care, we also encounter anxieties that are absolutely not related to a psychiatric anxiety, but they are the consequence of either the diagnosis or the treatment approach that we have chosen to treat a particular cancer. And this is often the case in leukemia and lymphomas. For example, many patients with diagnoses in this spectrum would take steroids as part of their treatment plan. Steroids in themselves can cause significant anxiety and can make patients feel sleepless, restless, and mimic very much what we would typically in psychiatry call hypomanic or manic states, in which the brain is just pacing at a pace that is so accelerated that patients would describe it as, I cannot follow my own thoughts anymore. I have 1 million thoughts at the same time. Important here to know that we need to look at the medication list, because this experience stops the moment we stop the steroids and support the brain to calm down again with counter-regulating medication. However, the most and number one reason for patients to experience anxiety in cancer is actually pain. And so we need to always also assess whether a patient is currently experiencing physical or emotional pain that leads to anxiety. There are other aspects that play a role more in other cancers, for example, hormone therapy, as for example in prostate cancer and other cancers, or hypercalcemia, which is often an important consideration to keep in mind when assessing anxiety in patients who have metastases to the bones. And then there is an element called existential anxiety. And I want to talk to this in a bit more detail. Existential theory is one form of understanding from a more philosophical angle, the predicament of human beings. So the same existential givens that any person, be they cancer patients or not, would be faced with based on the sheer fact that you're alive. And Karl Jaspers is a psychiatrist and existential philosopher who thought about this quite a lot. And he defined those aspects as limit situations. Because we are born into the world, because we were born without signing a contract about the rules of living, we are finding ourselves having to somehow navigate and maneuver through life, encountering situations that we cannot prevent because we're human beings, because we are alive. Such situations would be reminding ourselves of mortality, feeling shame, guilt, and having to simply somehow work with these experiences, for example, because we have regrets or because it is simply the fact that we need to deal with grief because we've lost something or someone. These limit situations from existential perspective are opportunities for growth. They are, while they are painful and can sometimes lead to despair, at the same time, enormously important opportunities to look at what's meaningful in one's own life, what the sources of hope are, and what the sources of meaning making and new meaning making in a changed life situation like a significant cancer diagnosis can be. In this context, we speak in psychosocial oncology often about the idea of double awareness. Double awareness is the attempt to balance both the shock of a diagnosis, of a cancer diagnosis, the shock of the need for significant treatment, for example, like a bone marrow transplant, the knowing that this can cause significant risk to one's own life, that it can cause significant concerns about losing someone, but at the same time, that there is a life orientation which balances out those more difficult thoughts by being focused on what is still possible, what is still available in my own quality of life while I am here getting treated, receiving care. One way of stabilizing the sense of double awareness and focusing more on life orientation is to look at the concept of symbolic immortality. This is a very important concept from a psychohistorian and psychoanalyst called Robert J. Lifton, who lives in New York and who was born in 1925. He's still alive, and he has defined those following 5 modes. And the way he came to those modes was that he says, any human being, when they think about it, would agree to the fact that in 100, 150 years, we will all be dead. That is a fact of life. That's an existential given. However, that doesn't deter us from living our lives. So how do we do that? How do we, on the one hand, know that we don't exist forever, but at the same time, live a meaningful, fulfilled life with happiness, hope, and joy? And he says most people have one main source of energy, of meaning that they draw from. Sometimes people have a mixture of them, but often there is one main source. And this is quite helpful to know for a psychiatrist in cancer psychiatry, because this helps me to choose the right interventions for the right patient. The biological mode is the first mode, and that's the mode of having families, having offsprings, having people who talk about me in my presence and in my absence, people who keep me in their mind, people who also show me that there will be a lifeline that continues no matter whether I'm there or not. The theological mode is the mode of having a firm conviction that there is a transcendence that goes beyond my pure existence and being here in the here and now, something that is there for me in the afterlife. A third mode, which is important as symbolic immortality, is the mode of creativity. By creating something lasting, something that is important for others, something that has a creative artistic value, we can create a sense of meaning and stability in life that goes beyond us ourselves. The mode of eternal nature is the mode in which I realize that entropy will always make sure that even though my physical existence one day in the far future might no longer be here, my molecules and my going into nature will, from a molecular level, always be present. And then there is the experiential transcendental mode, which is the mode of transcending any need for time and space, which is basically the mode of enlightenment. And he speaks about this mode as being a mode only very, very few people ever achieve in life. What now are specific anxieties? And I just want to also, again, refer everyone who's watching and listening to the QR code here on the right-hand side that will further explain in more detail these specific anxieties in cancer. One anxiety that I often encounter, and it plays a huge role in taking care of patients and families in cancer care, is fear of recurrence, FOR. It's one of the most common forms of cancer-related anxiety, especially, of course, after treatment has been completed. And it's one of the most significant emotional disturbances that can actually be very, very difficult for cancer survivors. Patients who are cured from their cancer, but who are having a gnawing sense of anxiety around the idea of potentially having a recurrence or relapse. This can become a very crippling anxiety, and addressing this very early and actually speaking about fear of recurrence as a concept at the beginning of treatment can be preventative in developing significant fear of recurrence. Another term that's important is the term of scanxiety. Scanxiety is a relatively new term that's often used, especially in more colloquial terms, for patients who are worried about their next upcoming scan. In lymphoma and leukemia, one can think about this, especially in the concept of the next biopsy or the next blood results, showing whether cell counts are gone up, are gone down. And these scanxiety can also in itself be a form of fear of recurrence that can be enormously terrifying and cause significant physical and psychological distress the closer a person comes to their regular next appointment, and can completely dissipate the moment good results come back and the findings are clear. The last aspects I want to mention in the context of specific anxieties that we need to keep in mind in psychosocial oncology is survivor's guilt. It's a form of anxiety that often can be reaching a degree of despairing even, For those who have been cancer survivors, especially after bone marrow transplants, knowing that surviving such a intervention such a treatment can at times be extremely difficult, with a lot of sequelae, with a lot of follow-up appointments necessary, and also finding that not everyone will in the end eventually have a successful treatment. This can lead in some patients to significant self-esteem, anxiety, and depressive symptoms that need to be addressed and need to be treated. I want to hint clearly to the web link down here from the International Psycho-Oncology Society. It has a very exhaustive, comprehensive resource list for treatment forms and treatment background websites for those specific anxieties in cancer. And I would encourage you to take a look at those. Again, the QR code will lead you to the same website. When we talk about depression in cancer, I want to emphasize again that very often we meet patients with cancer treatment who are experiencing depression for the first time in their lives. This can be very late in life, and it can be quite disturbing and unsettling because it really changes the perception of the world and how patients relate to the world. Treating depression in adults with cancer is very clear and straightforward once we have diagnosed it and once we are aware that we're actually dealing with a depressive syndrome. And we need to, however, make sure that we are not mistaking something for depression that actually is something very different. And I will talk about this over the next couple of slides. We do differentiate between mild, moderate, and severe symptom severity. And depending on the severity, we will have different forms of treatment. As I said before, it's called stepped care model. Typically, we will offer psychoeducation, explaining to patients and family members what the symptoms are, why they are there, how you can actively treat them yourselves by behavioral activation, by daily exercises, not over-exhausting yourself, but doing your 2,000, 4,000 steps a day, and by staying actively engaged with your social communities, as far as that is possible within a COVID environment that we're all living in globally around the world at the moment. If the symptoms are persistent, then there will be low intensity psychosocial interventions that we would be offering, and we would slowly maybe be starting thinking about medication. But if we are still at step 2 of care, we would not, as a standard of care, offer medication. At step 3, when we have a persistent depressive symptoms picture with a clear identified focus of clear depression, clinical depression, then medication treatment combined with talking therapy would be the standard of care. And in a step 4 situation with complex depression, with potentially even very dark thoughts going into suicidality or self-neglect, or even in the worst case, psychotic features, we would probably consider psychiatric, more intense and complex care, including admission to an inpatient ward. The majority of patients will have mild to moderate depressive symptoms. Going back to the first slide I showed, it is about 10 to 15% of patients who need more specialized care. Everyone else still needs care and still experiences significant distress. Coping with cancer and finding hope during cancer treatment is part of a project from the Canadian Psychosocial Oncology, and you can find the website Coping with Cancer, an excellent patient and caregiver-facing website with very concrete and specific ideas of how you can get help and how you can help yourself as well. You can find, if you just Google Coping with Cancer, or if you use the QR code here on this website, and it'll direct you to the platform. It's for free. The access is for free. Everything I'm sharing with you is accessible for free. Now, I just said depression is not always depression. And over the next couple of slides, I would like to talk to you a little bit about what the differences could be, where we need to be careful not to mistake the one for the other, because treatment and also understanding of the different other concepts can be completely divergent from how we would typically treat depression. The first thing I want to mention is the difference between grief and depression. All of us at the moment during the COVID pandemic experience some sense of loss and some sense of grief over those losses. Grief is a natural part of normative human experience. It is part from speaking from existential theory of what it means to be alive and be a human being. However, grief can, of course, reach a level where it becomes so debilitating that it can switch over to a depressive state. Or in the case of losing a significant other or a significant pet for that matter, losing anyone who's been a significant emotional bond to ourselves can lead, in the worst case, to so-called prolonged grief disorder, which is defined as being in grief for more than 6 months after the loss of a significant other. Now, I want to allow myself a statement as a psychiatrist and psychotherapist and say that particularly in the European culture, but actually anywhere around the globe, grieving is typically conceptualized as something of a year at least in the past and last 200 years. In Europe, it was typical to wear certain identifiers, certain clothing to demonstrate that I am in active bereavement and loss and that I'm grieving. And this is not just for 6 months, but typically 12 months or even longer. So the question around prolonged grief disorder and whether grieving longer than 6 months is actually worth a diagnosis or not is an open question that we're discussing in the psychiatric community. But I think what's important here is that it draws attention to the level of distress a person can experience when they experience prolonged, intense grief symptoms. The main difference between grief and depression is that in grief, we're trying to reconstruct meaning. We're actively trying to find a way of moving on to a new chapter in life in which the person or the loss we've experienced does not necessarily need to be gone, but their physical absence in our lives leads us to identifying new ways of living. That is typically not the case in depression, where meaning making is not part of the process. I want to specifically talk to the idea of continuing bonds. Continuing bonds is the idea in grief where if we have lost something that's important to us, and that just doesn't need to be a person or a pet alone, it can also be an idea about ourselves, about the person we wanted to be and can no longer be because of our cancer diagnosis, or the treatment side effects that make us become so much weaker than we were before for a temporary moment in our life. Continuing bonds is a concept that describes how we can keep in touch with inner objects, with inner representations of something we used to be or someone we used to be in touch with before. We no longer believe that grief is the process that ultimately makes us accept the absence of something we've lost. It's quite the opposite in modern grief theory. I want to specifically draw attention to those who are listening and might be of a First Nations background, that the QR code in the lower right corner specifically leads to a resource that identifies First Nation specific grief rituals and understandings of grief. And I find this resource enormously interesting, and it has helped me very much to appreciate again how much I can learn every day as a psychiatrist about how different experiences and lived experience can be. Another concept I want to differentiate is the concept of depression versus demoralization. While many people have a pretty good understanding of what it means to be depressed, to be low in mood, and to feel anhedonic, Demoralization is a concept that we need to separate from depression because it is treated in a different way. Demoralization speaks to a persistent inability to cope, a feeling of helplessness and hopelessness, to subjective incompetence and diminished self-esteem with a challenge to one's sense of meaning and purpose. The main difference is that in demoralization, patients are often still able to experience joy in the here and now. And a good example would, for example, be that a patient feels they have very little to no hope about the future, but they're still very much enjoying being with their family members, their grandchildren, but they're becoming quite sad after the fact of a meeting, thinking about the rest of their day or the rest of their future. This is important because we would be treating not with medication, but we would be treating with talking therapy primarily. And we would also see better effects with talking therapy interventions, such, for example, as CALM, C-A-L-M, which is a short-term psychotherapy developed here at the University of Toronto and our center here at Princess Margaret. Another point I want to make, and I think it's a particularly important point in the context of leukemia and lymphoma treatment, is to differentiate between fatigue and depression. Many patients, way too many, unfortunately, are experiencing significant cancer-related fatigue in the context of leukemia and lymphoma treatment. Fatigue can in itself have a significant impact on the motivational system. We talked about it at the very beginning. And because motivation goes down so much, it can sometimes seem that someone who has experienced significant fatigue seems depressed. If that is not the case, if the patient is actually not depressed but fatigued only, we would be treating with a completely different medication approach with psychostimulants, which are medications that would give you energy and that would make you feel more awake during the day. The same medications would, however, not be typically indicated first line for treating depression, at least not first or second line. So it's really important to make a distinction between depression and fatigue. And I think most of those who are listening and have own cancer experience going through treatment will know what I'm speaking to. It's not just your physical exercise exhaustion you would have after a gym workout. It is a much deeper seated sense of being drained, of feeling heavy, of feeling almost like a magnet is pulling us down. I want to finally now come to our segment around trauma. And when we talk about trauma, we're talking often not just about one particular event or one singular incident, but very often we talk about, in the context of cancer care, a prolonged, repetitive pattern of overwhelming experiences. And I want to introduce the idea of allostatic load or allostatic overload. It is a cumulative multi-system measure, a new concept that has been developed over the past 15 years, very much speaking to the physical healthy responses that we have as human beings to stress. The three main systems are mentioned here that are typically summarized under the allostasis system is the sympathetic nervous system, the HPA axis, and the immune system. And these three systems work together, and they need to work together to buffer us from any form of stress, be it a stressful day at work, be it a stressful emotional experience in a family conflict, or be it the stress of being confronted with a new diagnosis and its treatment. Short term, this allostatic system is keeping us from having significant stress experience, and it protects us to stay stable and become resilient. If, however, the healthy stress response system is overactivated over and over again and becomes overwhelmed, then the allostatic load, the stress load overall, can become an overload. And I want to show you a little depiction of this idea. A typical stress response is a good balance between stressors and my adaptability, my adaptation to those stressors, and it will even out in a good balance. If the stress reaction, however, becomes allostatically overloaded, then balancing becomes almost impossible because it's just too much, too heavy. The backpack becomes too heavy, and it can lead to a situation of rupture, an allostatic overload situation. And that's often the situation where cancer patients would come and talk to me and say, you know, Christian, I've been going through my life, I've been successful, I've been dealing with ups and downs, but now over the last 2 years, I had this diagnosis, I had this loss, I had two complications with the treatment, and I was so looking forward to getting this all done. And then I had another piece, and that just really was too much. That's the threshold where I couldn't take it anymore. And that's what we would call allostatic overload. A situation in which any person who would listen to the story would immediately understand that normatively, no person can actually really take this amount of stress. When we are in an acute stress situation, we can sometimes have a sense of disorientation, a sense of the world feeling unreal, us feeling slightly unreal, having brain fog, feeling as if we're a little bit walking besides ourselves. And sometimes we can even see ourselves outside of ourselves. All these stress, acute stress reaction symptoms are still normal and adaptive if they dissipate after a couple of hours or days. If they don't, and that is typically often the case in bone marrow transplant patients or leukemia patients or lymphoma patients who often get a diagnosis out of a very healthy state, a very healthy state of mind. They go to the family doctor because something is off, or they have had this headache, or they've felt this increasing fatigue, or there was this bleeding that they couldn't explain. And then within a very, very short period of time, they become inpatients and they get treatment and they get a significant sense of overwhelm. And this can sometimes then lead to something we call cancer-related post-traumatic stress, which is very, very similar to post-traumatic stress disorder, but it is often not as severe and can often be treated more effectively. Typical symptoms of cancer-related post-traumatic stress would be feeling defensive, irritable, very fearful, but not really knowing what exactly one is fearful of, being unable to think clearly, as I just described, having sleeping problems, avoiding other people or treatment-related settings, or having a loss of interest in life. As you read through these bullet points, you again see that cancer-related post-traumatic stress can impose very much like depression when really it actually is something different. And differentiating a depressed state from a post-traumatic stress state can help inform the treatment plan. If you want to understand more about post-traumatic stress, please go to this QR code. There is a really excellent resource website with a lot of background information and very pragmatic steps to helping yourself and your loved ones if you're finding yourself in a similar situation. The treatment for cancer-related post-traumatic stress may at times be the same than post-traumatic stress disorders concept-wise. It will just be less intense and also often not as long. It will not have to be as long as it would be in a significant post-traumatic stress disorder in someone who is who is in a different, more prolonged or early adverse childhood experience traumatic stress situation. However, I want to mention one thing, and that is if someone is already prior to cancer treatment in a situation of post-traumatic stress diagnosis, then their likelihood of developing cancer-related post-traumatic stress is more than tenfold higher. And this is extremely important for providers to be aware of, so that we can involve psychotherapists and psychiatrists very early in the course of treatment to prevent further harm. Crisis intervention techniques, or what we call psychological first aid, PFA. Again, the QR code up here will lead to a specific, clear description of what that means, is what often helps the most. So if someone is in a very distressed state of mind, relating to feeling completely overwhelmed by the amount of information and also the heaviness of a very significant diagnosis, it helps to really be very, very basic in the approach of support and containment, providing a safe space that cannot be intruded by anyone who just knocks on the door, creating a space of reminding someone over and over again where they are, who's with them, what my name is, offering something to eat and to drink, making sure that they are warm, that they have a blanket, that they can feel safe and enwrapped. All these very simple steps are often extremely important in someone who is acutely traumatized. I want to last speak, and coming to the close, about post-traumatic growth. While cancer and cancer treatment can, without any doubt, be a significant life-altering, life stress event, they also pose indeed an opportunity for change, for insight-oriented reflection, and for finding out what's really important in one's life. This will often happen as a positive behavioral, emotional, or cognitive change following cancer if a person is actually actively adapting to trauma. What's needed for this, and we have research around this, is not just the cancer diagnosis and treatment alone, but patients need to have a certain element of psychological mindedness. There needs to be a willingness to actually look at the meaning of the trauma experience and what the meaning implies for a new changed sense of self. I would like to finish today's presentation, and I'm looking forward to the questions you might have, or specific treatment questions you might have now, but I would like to finish with a short video which was produced by my colleagues in Belgium, the Mimi Foundation, around moments of carefreeness in a situation of cancer treatment. I'll share it with you and we'll talk after.
Ça fait 2 ans et demi que je suis dans la maladie. Et le problème, c'est que je ne suis pas guérissable. Donc ça, c'est dur à accepter.
Ça a commencé l'année passée au mois d'octobre, quand les résultats sont tombés. Donc j'ai fait un cancer foudroyant du poumon. On vit quand même toujours avec une épée de Damoclès sur la tête. Et on ne peut pas s'empêcher de ne pas y penser.
On perd l'insouciance complètement quand on apprend qu'on est malade. Surtout que moi, j'étais très insouciante de la vie. Je la croquais à pleines dents. Enfin, j'aimerais tellement la croquer comme avant. Pour l'instant, c'est pas possible.
Dear audience, as I cannot see you, I am looking forward to the questions you might have shared with the other panelists. I do want to reach out and say that for some of us across Canada, it might be a time of loneliness, a time of isolation, and a very terrifying time. I do want to invite you to reach out. You are not alone. There are many other people who experience exactly the same, exactly what you're experiencing at the moment. And please be in touch. We will try whatever we can to support. Thank you for listening today, and I'm looking forward to our discussion.
Well, thank you very much, Dr. Schulz-Quach, for sharing your expertise and the insight with all of us today. It's now time for a question and answer, and there has been some questions coming in. Excuse me, if you haven't done so already, do please put some questions or put your question in our question box on the Zoom webinar panel. And we will try our best to get to as many of the questions as we can. If we're not able to answer your question live here today, the community services manager in your area will reach out later to help you find the information that you're looking for. So just starting with some of the questions that are, excuse me, that were sent in a little bit earlier. We are trying to answer a question that's somebody is looking for coping tips for somebody who's 81, who feels like they're 71 and not really ready to depart yet.
Thank you very much for this question. Well, the not being ready to depart yet implies that the person is thinking about departing. And what I want to say is, first of all, well, don't depart for now. Really stay connected with life in the double awareness sense, as I discussed earlier. Double awareness by accepting that you're thinking about departing, that it is something that's on your mind. So don't try to push it away and spend a lot of energy in trying to avoid it and not to think about it, but to give yourself a holiday from those thoughts every now and then by intentionally and actively engaging in life with every power you have and all the energy you have. I think that the balance of both will lead to a situation for many people, not for everyone, but for many people, where there is space to openly, authentically discuss those existential thoughts and existential worries that are there, but at the same time to park them for moments in life where you then can fully embrace the living moment in the here and now. This is what I can say concretely and specifically at the moment to someone who is 81 but feels 71. Go on.
Excellent answer. Do you have any strategies for living in the moment and not thinking too far ahead?
So this now speaks to worrying and sometimes in the worst case ruminations, where the thinking ahead is basically it's almost like an obsessional way of going back over and over and over again. There are all those mechanisms that are stress response related that can help. So we can use breathing techniques. We can use mindfulness exercises. We can use relaxation techniques like progressive muscle relaxation, or getting a massage. This will, however, only work if we're still in a space of stress reaction where our stress system is able to respond to positive intervention and basically downregulate. If we're already in a situation of such acute stress that we're in an allostatic overload situation, then our stress reaction system will no longer regulate down. And what we then will need to do is really seek active psychotherapy support to better understand how we can change our thought pattern, cognitive behavioral therapy, or how we can actively embrace our need to look further into the future and understand why this is so important for us. This would be more insight-oriented psychotherapy like psychodynamic or existential psychotherapy.
Excellent. So the next question is, How can we as caregivers give day-to-day support to someone who is experiencing demoralization?
So this is a very important question. All of them have been excellent, but this one is very important because it puts the caregiver into a situation of enormous distress. Because on the one hand, again, in a demoralized situation, different from depression, the here and now enjoyment is still possible. But the moment the here and now distraction, if you will, is gone, the person will go into a quite deep state of sadness and despair. I want to again suggest in a very pragmatic way to find a balance between addressing this despair and helping to avoid the despair through here and now interventions. I want to speak to the addressing the despair. One way of really approaching this is by sitting down with a family member and sharing with them as a conversation starter how you are feeling about observing their distress. It could be, for example, something along the lines of, I've been observing you carefully over the last couple of days, and it's becoming harder and harder for me to see how you're struggling. But I do want to understand your struggles better. Would you be willing to talk to me about what it actually means to you struggling this much and how it feels to be in so much pain? Sometimes such a simple intervention can lead to feeling acknowledged and recognized in one's own despair. Those are not easy conversations. They can be very emotional, but they can lead to a relief and a release, and they can lead in a demoralized patient, different from a depressed patient, to a sense of connection, of having a bond that can paradoxically then increase the sense of hope.
Excellent. So the next question is actually centered around COVID, and I was kind of wondering if questions were going to come up about that. So COVID vaccinations have apparently not had a great efficacy for people in the blood cancer community, and so they're very, very scared. It seems that they've been told to be vaccinated, but continue to live as if they're unvaccinated. And coping with this is becoming very difficult as it goes on longer and longer. And they find that people in their families and their circle just don't understand why this is difficult. How can they talk to the people in their circle to understand and get them to realize that while they might be vaccinated like everybody else, they still have to act as if they're unvaccinated?
This is a very good question. And if I already had a completely formulated answer, I would be very proud of myself. This is such a difficult, I don't just want to give an expert statement here about something that I cannot fully formulate, but maybe let me try to say this. I personally, putting myself in the position of someone who has a compromised immune system, I would probably try to steer them away from the vaccination alone. And I would like to try to steer them towards the attachment and through our connection. And I would probably say something along the lines of, let us for a moment park or bracket the discussion of being cautious or not after vaccination or not. Let me ask you this. Do you want me to be alive? Yes or no? And if you want me to be alive, you need to understand that I need to do everything in this vulnerable state of my treatment to protect my life. And this is why I will not be able to do this, that, and that. I would probably do something along the lines of a relational intervention and would not try to go too much into these so dichotomized, vaccination, yes or no, good or bad, helpful or not helpful discussion with someone else. I hope I'm at least partially answering the question the person has posed. A very important question. There will be better answers from other people.
Sounds good. So the next question starts out with, hi, and thank you for all the fantastic information. This person is wondering if there is any talks about making a, having a cancer patient see a mental health practitioner as part of an initial treatment plan and not something that comes after when the symptoms start.
This is wonderful, and thank you so much for advocating on our behalf. I can share two things. I can share that first of all, we now have increasing research that shows that, as a matter of fact, particularly so in those who have no prior mental health history, using psychosocial interventions prior to the fact can actually prevent the development of a depressive episode. Our own team here at Princess Margaret, spearheaded by Gary Roden and Sarah Hales around the CALM intervention as short-term psychotherapy intervention, has demonstrated exactly this in a randomized controlled trial, that those who go through those 3 to 6 sessions of psychotherapy will actually have a much, much lower risk of developing depression along the line, along the way of their cancer treatment. We also are at the Global Institute of Psychosocial Palliative and End-of-Life Care actively advocating for the human touch in cancer care. And we have a big conference coming up early next year, which will focus around this particular matter. So if you're interested in this, please look up GIPAC, the Global Institute of Psychosocial Palliative and End-of-Life Care. All of this is part of the plan in this conference, and we're going to talk about how we can implement early integration, not just in other fields like palliative care, but really early integration in psychosocial oncology to prevent mental health sequelae.
So I think this might be our last question. And one of the things that I hear as a community services manager a lot is the watch and wait for chronic cancer is very hard. They sometimes feel they wish they had never gotten a diagnosis because they're not really doing anything other than watching and waiting. So how do you deal with the emotional and stressful feelings of a watch and wait, knowing that, you know, the next time you go, there may be a need for entering active treatment?
You know, I must quite frankly admit, the idea of having a diagnosis and then getting told that, well, we will see what happens, is something that I find terrifying myself. There are many terrifying things I can think of, but speaking to this particular question, I personally would probably seek psychological support. I would not expect of myself to be able to just stomach it. People are different. Everyone is different. For some people, it might be not a problem at all. For some persons, it might be absolutely unbearable. But again, and that's something I do so often in cancer psychiatry and psychosocial oncology, I'm always asking myself first, as I listen to this question, is, can I relate to what the person just said? Can I understand it? And absolutely I can. There is nothing, absolutely nothing not normal about the fact that one is terrified in a watchful waiting scenario. It doesn't really matter what the statistics say. It matters that any person's mind after a diagnosis would go to the worst outcome as a possibility, and that is only normal. So again, my specific suggestion would be, go to the Coping with Cancer website as a starting point, look at what is really excellently available there already. And then if you are interested and willing, reach out to local psychological and psychotherapeutic supports. Do not take medication, because that is not a question that you need to deal with medication.
I'm going to sneak one more in and then we'll wrap up. But what can you recommend to somebody who is waiting for an appointment with a therapist, knowing that sometimes that wait is a long period of time?
I cannot be simple-minded about the fact that we have to solve a significant structural issue in Canada, as in many other countries around the world, about access to care and access to psychotherapy. And this is, we are aware of it. It's a responsibility we have to shoulder, and we're trying to get better. For those who are waiting, I can say there are some genuinely excellent resources online. I can specifically say this now, paradoxically, during the COVID pandemic, because people were forced to use virtual environments, and virtual environments were redeveloped and much more complexly developed in a very short period of time. In this regard, especially also for those who are in the audience who might be living in a more rural area where access to psychotherapy in person might not be so easy. I very much encourage you to go through the QR codes that I've shared with you. And if any of you has difficulties accessing the QR codes because you're not familiar with using them, I will be more than happy to share here with the team the clear code websites so that you can look them up individually. We'll be happy to share this information with you.
Perfect. Thank you so much. So that'll be the end of our questions. If you could advance to the next slide. I just wanted to thank you again for being here with us today and for answering all of those questions for us. The feedback in the chat and the questions has been really overwhelmingly positive, and I think that you've helped quite a few people. We would like to also thank those who have made the conference possible, our marquee sponsor, Astellas, as well as AbbVie, AstraZeneca, Bristol Myers, Squibb, Janssen, Jazz Pharmaceuticals, Merck, Novartis, Paladin, and Pfizer. And next slide, please. So before we sign off, I would like to remind you all that you're not alone. We're here for you. Please reach out for more information about any of our services by calling toll-free or by emailing or by the email that's listed in here on your screen. Also, be sure to tune in to the rest of our Living Well with Blood Cancer conferences throughout this week. For example, the next one is titled Blood Cancer and Sexuality, what you need to know, and it's scheduled for the 23rd at 3 p.m. Eastern Time. It's not too late to register for any of the upcoming conferences. You can visit Blood Cancers conference.ca to register. And thank you for joining us again, and have a wonderful day.